definitely been a busy week, so I'm glad to see Friday get here. Hopefully you were able to participate in last week's webinar. If not, it's not a big deal because it's part 2, but it's really 2 distinct presentations. So it was very heavily data-driven last week, just talking about the epidemic and the epidemiology behind the epidemic of prescription drug abuse. So now I want to talk today more specifically about how to best engage with healthcare professionals because I think with this particular drug problem, there's no way to really make any inroads in the situation in our local communities without engaging with medical professionals. So I'm going to start out here with a little question, and I know we don't have many on the line, but prescription drug abuse starts with one thing. What is it? If anyone would like to chime in.
A prescription?
Thank you. That must be Alice.
Yep. And I'm having a hard time hearing. I'm going to look for some speaker to see if I can do it on my end. But
okay, well, let me get a little closer to my phone. Maybe that's it. Is that better?
Yes, thank you.
Okay, sure. So, just like Alice chimed in and answered this question, it does all start with a prescription. And a lot of times I think we as coalitions focus more on getting the prescriptions out of the household, which is an important piece of work too. But if you really want to go upstream of the issue, you really need to look at trying to curb prescribing to begin with, because if the prescriptions aren't written, they're not going to be in the home to begin with. So I've tended to focus, not that I don't focus on medication disposal because it is critically important, but I also think efforts going upstream from that and curbing prescribing can be just as critical. So most of us are familiar with where people are getting their prescription medications, and this is why I think people on that first question I asked may get it wrong because they see all this. Most are getting it from family and friends. True, but family and friends wouldn't have it, again, if they weren't prescribed these medications at one point in time. So I think it's important that we continue to keep that in the back of our minds. I'm going to start a little talking about prescription drug monitoring programs because, again, I think as you're working with medical professionals that you kind of understand the whole concept of prescription drug monitoring programs and really how long they've been around. Because one thing that I've found is very critical, if you're not well educated and well versed in the issues that they're dealing with on a regular basis, then it's really hard to find some common ground in which to have a conversation around this particular problem. So the first prescription drug monitoring program is really interesting, goes all the way back to 1918 in New York State. So this concept's been around for a long time. The drugs at the time that they were concerned about, at that time cocaine was actually not a Schedule I illegal substance like we know it now, morphine and heroin. So it was to track those three drugs in particular. The state had a role in bringing it up, and then the doctor's role was really, again, it was used as a tool. There weren't the mandates that we see now, but the pharmacist's role was really to copy this to the state and give to the state within 24 hours of dispensing. So imagine back in 1918, you actually went and got a prescription for cocaine. or a prescription for heroin. But that's the way, it was before those drugs got moved to an illegal status. Early prescription drug monitoring programs, so from 1939 to 1943, California had the oldest continuous program, which started in 1939. Hawaii got on board in 1943. 1960 to 1989, you had Illinois, who started theirs in 61, Idaho. I think that was supposed to be 1967. I apologize for my typo there. Pennsylvania, 1972, New York, 72, Rhode Island, Texas, Michigan. So you can see, we think of it as a fairly new concept. At least that's what I thought until I started doing the history on it, and realized that the whole concept has actually been around for quite some time now. So some of the early characteristics of a PDMP was, a lot of it was really law enforcement driven, and designed really to curtail diversion of these substances, which is what we're seeing a lot now with our prescription drug abuse program, or problem, is that there is a lot of diversion of pills on the street. And so that particular reason for starting PDMPs is still with us today. So they collected only Schedule II drugs. We know that our PDMPs today are Schedule II through 5, so we're getting, all the scheduled drugs. Use of state-issued prescriptions was some of the early characteristics. So the state actually issued their own prescriptions to physicians and captured that data using that state process. So now, we have the DEA, the Drug Enforcement Administration, really at the center of the prescription monitoring in terms of who can prescribe controlled substances. So the frequency of collecting data was actually 30 days from the time of dispensing. So then we hit the electronic era. Wow, can you imagine all this being done paper records? Well, now we're up to the electronic, and of course PDMPs changed a lot then. So in Oklahoma, they were the first to require electronic transmission of data. And of course this reduced cost tremendously, as you can imagine, increased accuracy and timely submissions, and then enabled other states to consider PDMPs. But it still really didn't catch hold until the opioid problem that we're seeing today. So in Nevada, they were the first to require the reporting of more than Schedule II drugs. So they were the first ones to go 2 through 4 actually, first to provide unsolicited reports to practitioners. So they were actually sending information back to their prescribers. So it was more than just a diversion tool at that point. So our present-day PDMPs came about really through the Harold Rogers Prescription Drug Monitoring Programs grant in 2003. Harold Rogers is a legislator from Kentucky and has really been engaged in this particular problem. And lucky for us, he sits on the Finance Committee and holds a lot of purse strings. And so Kentucky in particular has really benefited from getting some extra federal funds into their state. But this allowed grants to states where you could apply for grants to either put a prescription drug monitoring program in place or enhance ones that you already have. So the program was actually administered by the Bureau of Justice Assistance. Again, kind of going back to that original purpose, is we have these to prevent diversion and to identify, what we call today doctor shopping. But PDMPs have taken on, like in our state, in Tennessee, our PDMP, which is called the Controlled Substance Monitoring Database. So we call ours the CSMD, lots of acronyms in our world. Ours has always been under the Board of Pharmacy, so it's been more healthcare driven than it has been law enforcement driven. And in fact, law enforcement didn't even have access to any of the information in the Controlled Substance Monitoring Database in Tennessee until several years ago, where they had to pass through legislation allowing them access in the event that there was an active investigation going on. So that's still in place today. So there's a lot more collaboration now than there was. So that's why you see that it went through the Bureau of Justice Assistance. So in 2003 to 2012, 33 states enacted PDMP legislation. And of course, SAMHSA, CDC, DEA, ONDCP, all of these federal agencies were involved in pushing that as a priority as a state. Each state should prioritize this as an important measure in curbing prescription drug abuse. So the next generation, again, what we're seeing now is we're trying to get these PDMPs to talk to each other because as we know just in the work that we do in our state that our problems don't stop at the county lines, nor are they going to stop at the state lines. And with Tennessee being situated and bordering 8 states, it's very easy for individuals to cross over state lines and fall under the radar screen and basically get as many pills as they can get in Tennessee without, being red flagged, and then crossing over into Kentucky or North Carolina or Georgia or, one of our other bordering states, and working the system there as well. So this interstate data sharing is becoming more and more imperative as time moves on in order to curb those types of behaviors. And also from the medical provider side, it's important if they're checking the database that they have as much information as they can on their patients. So Tennessee is connecting now with some other states. I want to say there's 4 or 5 now that they've been able to create collaborative relationships and be able to share data in a secure fashion. But that takes some money as well to have those interfaces, so those web interfaces. And I'm not a techno person, so I apologize. I don't know how all that works, but I know that you have to be able to secure that data so that it doesn't breach confidentiality. So real-time collection of data, is what we're seeing more and more of now. Tennessee's data pretty much within 24 hours is up to date now, whereas just a few years ago, we had 7-day turnaround time on data collection. Now it's pretty close to real time, but safely within 24 hours. And then integration into health information exchanges, again, being able to integrate as much as possible is going to be what we see in the future. So if you have electronic health records, is there a way to connect the electronic health records in the CSMD so that doctors don't have to sign into a totally different database to look up their patients? And that's kind of tricky business too, because there's a lot of different companies out there that produce the software for electronic health records. PDMPs as part of the standard of care has really been pushed with this new generation. Again, this is why I really wanted to cover this before we got into how to work with healthcare providers, because we're really trying to push this out there as it's a tool for you to use. It's not just a, I got you, you're over-prescribing, but it's a tool for you to best manage and care for your patients. And then also the unsolicited reporting that can be done through PDMPs. So if a doctor has several patients that they are providing care for who are above what we would consider a safe level of prescribing for certain medications. Right now there's a flagging system within the CSMD that's built in there that will show up when you pull up a patient, a red flag for somebody who's at a very high level of morphine equivalence. But eventually they would like to get it to where an email or a message actually goes out to that physician to say, hey, you may want to check into this. So hopefully we're going to get to that point in Tennessee, and I know they're working on that utility right now. So standardization of programs, again, that's critically important to have the interstate data sharing, is to have similar utility for the different programs in the different states so that they can eventually talk to each other. And increasing authorized users of the PDMPs, and again, that's what I mentioned earlier with allowing law enforcement access. And in some states, it's the opposite. Law enforcement has access and medical providers don't. So, they're working on relationships in the reverse order, that we are here. So I want to cover just real quickly some relevant policies in Tennessee that impact prescribers in our state, because again, we need to understand the laws ourselves as prevention folks, so that as we get out and we start working with physicians, that if they have a concern about a certain law or they're feeling a little irritated over a law, that we at least understand the basics and can be able to articulate or ease any fears or concerns they may have over certain laws that have been passed. So, of course, the biggest one was the Prescription Safety Act of 2012, which required all prescribers who had a DEA and who were licensed in the state of Tennessee to actually register with the Controlled Substance Monitoring Database, and also to check it when they were writing a new prescription, and then check it every 6 months thereafter for patients who are on continuous controlled substances for medical conditions. So that act was due to sunset in 2016, and as you all know, there was a Prescription Safety Act of 2016 that passed that allowed this to continue. And we have seen a huge increase since 2012 in prescribers registered in the database, and so it's definitely had a positive impact in our state on the amount of data that we're seeing now in the CSMD. Pain clinic regulations, again, if you're working with pain clinic providers, but even if you're not, it's good to be familiar with the pain clinic regulations because before those went into place, pretty much any physician, as long as they were licensed in the state of Tennessee and had a DEA number, they could set up a pain practice. Now you have to have additional training in chronic pain management and be certified in through certain licensing boards in order to run pain clinics. So again, it's something, you don't have to know every detail of these regulations, but at least know, which providers are actually eligible to be medical directors at pain clinics now. And then the Naloxone and Good Samaritan laws. Good Samaritan, can apply to physicians too. And we need to make sure medical prescribers know that they can give a prescription to a layperson for naloxone and that their liability is protected, civil and criminal. And same with Good Samaritan, and that there are Good Samaritan laws to cover naloxone distribution. So I'm amazed when I work with our medical providers how many of them still don't realize that they can prescribe naloxone to lay persons. An ID bill, this is more for pharmacists, but when patients go and fill a prescription now, they have to have an ID if they're not familiar with a pharmacist. Now, if the pharmacist, it's an existing patient and they know them well, they don't have to provide an ID. But this is, again, is just a deterrent for those who are trying to work the system. Safe harbor law is important, especially when you're working with anyone providing care to pregnant women or women who could become pregnant. And that law basically says if a woman enters prenatal care and treatment by the 20th week of pregnancy and she has an addiction issue, she will not have her child removed necessarily just due to her substance use alone. Now, if there's other safety issues involved, DCS could still remove that child. But again, this is an important thing that medical prescribers understand and providers, because they're seeing these patients and they can help relieve their fears and anxiety if they do have an addiction issue, and encourage them to get into treatment if they're not into treatment at the time they enter prenatal care. And then fetal assault was a law we had on the books for 2 years, from 2014 to 2016. And it could charge a pregnant woman who misused prescription drugs with a misdemeanor assault charge. And that law did sunset, but it's probably going to take a while for everyone to understand that it's gone. And so our providers in our community especially need to understand that law and the implications, and also the fact that there may be a lot of women who don't realize that it's no longer in place. And then outpatient buprenorphine clinic guidelines, or clinic rules and regs just went into place the middle of January of this year. And those rules were written based on legislation that passed in 2016. But all physicians need to understand now, if they are sending them to an outpatient clinic, that they now are being regulated by the state, so they can have a little bit more of a comfort level knowing if they are sending them to a licensed clinic that they are being monitored now, because that's been a big concern with medical providers. If they find someone who is addicted and may need to be assessed and enter treatment, they didn't have a lot of comfort in knowing who to refer them to. So again, I think we're making some strides in our state to make sure that our clinics are using evidence-based practices in addiction treatment as well. So now we'll get on to engaging medical professionals. The role physicians can play is huge in this particular issue. So more than 80% of people in the United States have at least one physician visit and one contact with a physician every year. So that's 80%. I mean, that's pretty high. So they can be a huge key in helping us identify people who may be using medications non-medically, as well as just having addiction issues to begin with. SBIRT is screening, brief intervention, or referral to treatment, which I'm going to talk a little bit more about a little bit further on in the presentation. And then, of course, the use of the CSMD as a tool to best manage the overall health and well-being of their patients. Now, pharmacists, their role is really patient instruction. When someone comes in, they get a prescription for a new medication. They're required by law to instruct the physician, or instruct the patient when they pick up their medications. They can also be on the front lines to alert law enforcement to fraudulent prescriptions, or the possibility of fraudulent prescriptions. So they're taught, how to identify those. Sometimes they'll catch where, a prescription's been modified. Identify abnormal patterns of fills. Again, they have access to the CSMD as well. In fact, they're the ones that actually enter the information into the CSMD. So that's one thing that we all need to remember, is that the CSMD is not necessarily accurate in terms of number of prescriptions that were written, because until that prescription is taken to the pharmacy and filled, it's not entered into the CSMD. So when we see information on prescriptions, keep in mind that those are ones that are actually filled. And I don't know how many of you on the call, but I know personally, there's been times when, I've had a minor procedure, and they may have given me a few days' worth of a narcotic pain reliever, and I didn't feel like I needed it and never got it filled. So, again, the whole idea of keeping up with what we're doing based on prescriptions is a little bit misleading. So really the CSMD and what's being filled is what we need to pay attention to. And they also are great about contacting prescribers. So again, if they see some abnormal prescribing patterns and see a patient maybe getting more than they feel like professionally that they may need to be getting, or there's another medication that was written by another doctor that's in the CSMD that might cause a drug interaction. We see a lot of overdoses due to benzos and opioids being taken together. So those types of red flags, pharmacists are really good at picking up on, and you can contact that prescriber and say, give them a heads up and say, do you still want me to fill this at this level? And of course, they can refuse to fill too, and that's what a lot of people don't realize, is pharmacists, even though a doctor may have written a prescription, they're at the end line of the distribution chain, and if they feel like that professionally, that their professional judgment that it should not be filled, they can refuse to fill. So back to the medical professionals, and what's really important with engaging with them is one of the things that I did really early on was to identify who the respected leaders in healthcare are in my community. Because whether we like it or not, doctors listen to other doctors. And I'm not a doctor. And I appreciate that, but at the same time, it can be a little frustrating sometimes when you feel like you can't get their attention. So it's really, really critical to figure out who in your community of medical professionals are considered the top and respected leaders. So when they talk, they're like E.F. Hutton and everybody listens. And then go meet with them, educate them on state and local issues. I was amazed when I first started meeting with medical professionals how little they knew about the opioid epidemic. I think now there's been so much publicity and so much information being pushed out there, plus the laws that have been passed, that they're not quite as naive as they used to be. But when I first started these conversations, I was amazed. When I would show them the data, they were very surprised and shocked to see the steep upward trend. So understand their challenges. Again, it's real easy to want to play the blame game because, like we said at the beginning, the opioid abuse problem starts with a prescription. And so it's very easy to say those bad doctors. And so it's very important when you're going to be working with healthcare professionals that you don't point fingers at them because especially they feel under the gun right now due to the fact that, there's monitoring going on, the DEA is watching them, the state's watching them. They feel like they have a whole lot of different agencies and organizations kind of all, under a microscope, watching everything. And their perception is their reality, and that's what we have to remember too. That may not be really what's going on, but that's their perception. So you have to be able to meet them where they are, and be able to understand and appreciate where they're coming from. And drive your need for their expertise. And I apologize because I covered up part of my word there with my doctor picture. We need them. I mean, they're critical in helping to reduce this prescription drug abuse epidemic that we're seeing. So, we need their experience. We need their expertise. We need them to teach us what it is we can do within their system to help manage this problem. How can we reach their peers? And we've got to be extremely flexible. These are extremely busy people. If we can get some time with them, I don't care if it's, 7 a.m. for breakfast before they make rounds. We have to be able to adjust our schedules in order to meet theirs. Do I like getting up at 7 a.m. or being at a meeting at 7 a.m. To talk about this problem? Not necessarily, but if that's when you can get them there, then that's when you're going to have to make it work. So again, just be very professional and be willing to meet them where they are. And then they're trained to be very science-based. Everything is about what's evidence-based practices, what is the current literature seeing or saying about this. So it's very, very important that we make sure that whatever we're bringing them is really based on science and based on the literature, and that anything you can find in medical journals to support where we need to go and what you want them to do, even take copies of those studies with you. When I do trainings for physicians, I find things from their own associations, so the American Academy of Pediatrics, the ACOG, the American College of Obstetrics and Gynecology, where are their positions on these particular issues. And so, go to their professional associations, dig around on their websites, find white papers that they have on some of these issues, and have those ready so that they see that you're not kind of out there doing your own thing, but it's based on what their own profession is saying. And then be very measurement focused. They like to know, what are the numbers? What are the numbers saying? Where do we want to go with the numbers? So any project you do with them, make sure you outline specifically, and we do a lot of that, I know, in prevention anyway. So I'm kind of preaching to the choir, but just know ahead of time they're on that. Well, how are we going to know, that we're getting anywhere? So, and they're very interested in quality, so high quality is really driving a lot of healthcare right now. So how can we increase quality but yet not increase cost at the same time? So they're very quality focused. Time is limited, like I mentioned before, so be very efficient in your interaction with them. And then try to find practical tools, so just very simple things. If you want them to start doing things a certain way, if there's a tool or a guideline or something out there that's very simple for them to implement, that has science behind it, pull those tools and be able to give them tools in order to do the job. And then another acronym, I put GRRR because we're such an acronym world here. And I mentioned this earlier. SBIRT is an acronym for Screening, Brief Intervention, and Referral to Treatment. This is really what a lot of my focus has been on in our community in terms of educating medical providers, is really getting in here and getting them to understand that this is an evidence-based process that really should become normalized within their practice with all of their patients. So just quickly on that, screening is really just what it says. So you're quickly assessing the severity of substance abuse. So there's multiple questionnaires out there that have been tested. There's science behind them. Again, I mentioned science earlier. So they can choose, from a variety of tools to use if they engage in the expert screening process. But the first thing you have to do is the screening tool itself is just a series of questions that you ask a patient to determine whether or not they need the next of the intervention, which is a brief intervention. If someone does screen at risk for substance use or maybe have already gone over the edge and are actually needing assessment by an alcohol and drug counselor or may need referral to treatment, this brief intervention is the time where they talk to them about the results of their screening. So you're either going to motivate them towards a behavior change, so create a plan with that patient, or you're going to give them an atta-girl, atta-boy, they're low to no risk, keep up the good work, those types of conversations. If they are at risk, then they're going to have a conversation around if the behavior continues, some of the health implications. So not from a moral, judgmental standpoint, but more from how this can impact your health long term. And then what are some things you can do as a patient or as my patient to reduce your risk? So again, the physician is guiding conversation, but really wants the patient to come up with a plan to reduce the risk. And then again, if they're over the threshold of, we're beyond risky behavior, we're kind of already possibly maybe addicted, refer them to a treatment provider. So the reason I bring this up, again, is there's a continuum of substance abuse or substance use, and that we know most people are going to fall when you screen them into that 70% abstainers and low-risk users. And then you're going to have the focus area really for expert, which is those moderate to higher risk users, which are 25% of who they'll screen. And then you've got about 5% that'll end up being severe and dependent, meaning that there's not a whole lot the provider can do at that point other than refer them on to treatment for further assessment. But really what we're trying to target with expert is that moderate to high risk, that 25% group, because we have an opportunity there to have the biggest impact. So when we're talking about expert with prescribers, we're really thinking about this using a public health perspective. So we know from diabetes, I bring up diabetes all the time as a correlation with expert in terms of addiction and diabetes. Not that they're the same thing, but most of them get this whole idea of, for every 4 diabetics, and on here I've got for every 4 dependent users, so these are people who already have addictive disease, there are another 12 out there that are at risk. And maybe binge drinking or maybe, smoking marijuana, doing things that could possibly, they could cross over that line and become dependent users. So what we want to do is focus on those 12 folks during our expert screenings and try to get those people from crossing over and becoming dependent. So I equate this to people who have some pre-diabetic markers. So they're not diabetics yet, but if we don't have some conversations and do some interventions and create some behavior change, more than likely they're going to cross over. So again, showing them that they can have a great impact on a large number of people by doing something like this is a huge piece to drive home with them. And then really in the public health paradigm, all services are really aligned, and we know that working in prevention. We focus on universal prevention, but a lot of times you can't really ignore the selective and the indicated things that are going on in your community either. So the risky behaviors, indicated, people who have already started down that path. All of those things really can affect our universal prevention efforts. So ESPERT is really considered an early intervention. So it kind of crosses over between prevention and intervention. So it's a great way to get involved also in working more collaboratively with your addiction treatment providers in your community. So if you build it, will they come? Not necessarily so. When we first started doing our ESPERT training here in Knox County, we offered free continuing medical education units, which are usually pretty expensive for providers. We fed them. We felt like we had a compelling subject. We actually used our neonatal abstinence syndrome issue to really try to get their attention and get them there. And then doctors, we have physicians on our training team. Again, if I just got up there and trained them, they probably wouldn't listen to anything I said. But if doctors are on the training team, doctors listen to other doctors, and whether we like it or not, that's just the reality. But we still found ourselves really having limited participation in our trainings. So then we since have switched to a healthcare facility strategy. So we thought, okay, maybe part of the problem is that, they're having to leave work, they're having to travel, go to different locations. So we looked at, we could promote it within the healthcare system to those particular providers who are working within that facility. We could work specifically with that facility on what time of day would be best, what day of the week would be best. Again, just trying to make it more convenient. And then we continue to review our evaluations every time we have a training and continue to tweak our content of our presentations and really pay attention to what they're telling us. And then also realizing, that there's a lot of competing demands out there. And we're also understanding, too, now that there's a lot of online opportunities for them to get CMEs and, at 2 a.m. if they want to go online and they can't sleep and do a, 1-hour CME course, they can do that in their pajamas. So it's a little bit challenging trying to get them physically to come to anything. But once we've been able to get them there, we found that they learn a lot, they ask a lot of questions, and our evaluations have been, very good. It's just, again, it's a challenge trying to get them there. But we went from our first healthcare facility, I've got UT Medical Center on here because that's where we first had our first facility training, and we had 81 participants in that training, whereas the ones we were doing was more of an, I'll call it, a neutral location in our community. We would have at the most 29. So we were really happy about this and thought, yay, we've hit the mother load here. But then the next one that we did, we didn't necessarily see those numbers again. So again, it's going to vary by facility as well. So to kind of summarize here, another thing that is a great way to get them involved is by getting your diverse leadership, and I know we do this as coalitions anyway, but our coalition here in Knox County was more of a grassroots coalition, and my board of directors was more, the leadership level. That's where my sheriff was and my district attorney and those folks. But we really didn't have medical leadership engaged. And so I started a whole separate prescription drug task force in August of 2013. And I went to our Academy of Medicine and said, can you invite your medical leadership to attend this meeting? And to be honest with you, I didn't know if it was going to go good or go bad. When I did this, I was a little bit nervous because at that time, law enforcement was pointing fingers at doctors. Doctors were pointing fingers at law enforcement. And what I was doing was bringing all of them together. And I did it in the evenings. We have meetings in the evenings. But it was really interesting. By bringing them together, they really learned that they all shared some common, even though they're coming at the problem in different ways, they had some common concerns, they had common ground in which to work on, and it really brought them to a place where they all really appreciated each other's role in this particular problem. So we had pharmacists, and of course the medical folks. We've got treatment at the table. Pain clinic, certified good pain specialists are part of this group. And so it's been very, very meaningful for them. And they've stayed. A lot of my original folks that came on board in August of 2013, my medical leadership, are still engaged. So again, you've got to establish that environment where they all learn from each other, because that's really what they're hungry for. A lot of times I'm just the person who brings them all together, and keeping them reined in sometimes can be challenging. Imagine having 24 to 28 leaders in a room. They all want to lead, nobody wants to follow. But it really has been, it's given us an ability to really come together and develop some strategies that everyone agrees on and can all work together on. So we definitely went through, a process of establishing, the direction we wanted to go in, and then a lot of communication between meetings, and I'm kind of that conduit. If I find a good article on something that we've been talking about in that group, I send that out, and again, that just keeps them engaged in between the monthly meetings, and keeps them thinking about this particular problem. And, they've gotten to now, if they come across something, they share it. Celebrating success is huge, and then continuing to build. The worst thing you can do is have meetings where nothing's really happening and they feel like they've come and they've wasted their time. So you've got to keep the meetings going. You've got to keep them meaningful. You've got to have data. Again, data and science driving the decisions that you make within these groups. And then I don't know why this goes crazy on here. It was fine here a minute ago. But anyway, the controlled substance utilization, I just kind of wanted to show you that we're making progress in the state in terms of prescribing of controlled 2, which is the most powerful controlled substances by state. So Tennessee, unfortunately, ranks second, and we still have a ways to go there. And this is Schedule 2s. Some of the other stuff, you usually see Alabama in front of us. And that's all controlled substances, so this is just pulling out the top level of controlled substances. And so you can see the RX per capita there, where Tennessee ranks. And then this next slide actually shows you, this is controlled 2 substance growth by state. So this is even more important to look at, because you can see Tennessee's growth is way down there. So again, our growth is slowing down and the prescribing is slowing down, which is a very positive indicator. And these are the kind of things your doctors want to see. So just keep this in mind. And I know some of this data is a little bit old, but it's more of an example of types of data you can put in front of them to get them to understand the extent of the problem from the healthcare perspective. And then this last graph, this is an important indicator too, as you're working with medical providers. If you have limited resources and you really want to get to prescribers, the ones who are prescribing more, this type of data is very, very important to use, because you can see here, family practice and nurse practitioners in internal medicine, which unfortunately are our largest numbers of providers anyway, have the highest prescribing rate. So this is something good to monitor, because as we go forward, hopefully we're going to start seeing people who should be high prescribers, such as oncologists, hematologists, people who do surgery, general surgeons. They should really be in the top tier of specialists who are prescribing, because they have legitimate reasons to be prescribing at higher levels. So again, we hope over time this will change, but as you're targeting certain specialties, it's good to know this. Which specialty areas of medicine in our state seem to be prescribing at higher rates. So do we have any questions? I don't see any in the chat box. Anyone has any on the phone?
Jenny asked if we can get a copy of this PowerPoint, and Karen, would you be okay if I sent a PDF?
Yes, that'd be fine.
Okay.
And I apologize for some of the slides looking out of whack when they got up on the screen. I promise you in the PowerPoint they don't look like that. So. Okay, if no one has any questions, I appreciate your time, and anything I can do to help, just let me know. And I know some of you have some great ideas you can share with me too. So we all just are in this problem together, and I think we're making some progress, and we just got to keep on keeping on. But I hope everyone has a great weekend.
Thank you so much, Karen. And just remember to email me if you need a certificate for this training. Happy weekend, everybody.
Thank you.